Okay, here we are, everybody. We are back. Back with Dr. Sinada today. This is going to be fun. This is going to be fun. Just bring it to me. Or I'll eat it later. Okay. Let's get Dr. Sinada on. I already see friends. Jennifer, Dr. Lukoc, a lot of friends on here. Daniel's son, Dr. Amin. Cool. All right, let's get Dr. Sinada on here. So we're gonna go into the perio pros full arch treatment planning, digital workflow. We'll do a little bit of probably single teeth as well, but mostly with Dr. Sinada, it is full arch stuff. So let's get him on here. Okay. Also, for questions on today, make sure you write them in the question box. Sometimes they get lost when we are trying to talk and get to the questions. Okay, let's see. Dr. Sinada, onde está você? If you have questions now, go ahead and write them down, and we'll make sure that we get them. There he is. Hey.
There he is. What's up, man?
How you doing?
I'm good, buddy. How you doing?
Good. Doing well. Let's see how Instagram does today. See if it kicks us off or not.
Nice. When is it kicking you off?
Well, sometimes it's freezing. I think because there's so many lives happening.
It's just because we're breaking the internet.
That's exactly it. Yeah, we're like Kim Kardashian's butt. You know, breaking the internet.
Yeah, it's way too many bright shades of teeth. I love this new look you got, man.
Yeah, this is my kind of like a cartel, drug smuggler Miami look.
Yeah, I love it. I love it. See, the thing is, I don't know what the first button is. You could have the second button, or it could just be complete.
Yeah, this is infinite. My belly button's out, actually.
That's good. That's
so
awesome.
I hope you don't mind, but I was a little late with playing with my son, so I'm going to be eating a quiche while we talk.
How's the kiddo doing?
He's good. We just got them playing in the dirt for a while.
Dude, that's awesome.
That's awesome.
Honestly, that's probably been my favorite part about this quarantine is just getting like actual family time.
Family time, yeah. That's the thing. All the kids and dogs and cats benefit from this time more than anybody, right?
Yeah, it's so true. Well, so I got two kids, and my first daughter, she was born when my wife was my wife's a pediatric dentist, and so my wife was doing pedo, and I was in Ohio, and I was doing pros in Maryland, and so I only saw them like once a week. So I had to like commute.
That's crazy.
So, and now we have a 5-month-old at home, and I'm like spending more time with the family. It's awesome.
That's great.
You got to look at the positives, right?
That's right.
Oh, you're fine.
So why don't you give a little intro? Yeah, this is very informal. So family can come in. I'm going to be eating a quiche.
Nice.
We are going to be diving in.
Nice.
So why don't you introduce yourself to any of my followers and friends that may not know who you are.
So my name is Naif Sinada. Naif. I'm a maxillofacial prosthodontist. I practice in Arkansas. Again, we'll keep this real informal, so we'll be looking at the questions. If anybody has any questions, just throw them up there. But I'm actually in the office right now. That was my
nice.
My ceramist is looking over, like, is my suction too loud? I'm like, no, you're
Are you guys back to work?
Technically, we can be back to work.
Okay.
May 18th is our launch date right now. May 11th or Monday, we're going to start kind of slowly ramping up the staff and getting everyone kind of on board with what the new plan is and the new order. You know, it's getting, you know, just, I think it's going to take a week just to get everyone figured out, you know, here's how we're going to run things different. This is the protocol, et cetera. So, we have a lab in-house, and we have 3 prosthodontists, what we like to call surgical prosthodontists, for lack of a better word. We do full mouth reconstructions. That's essentially all we do. So, I mean, we still do a few cosmetic cases here and there, you know, interior work or family members and stuff like that. But for the most part, we limit our practice to full mouth reconstructions on implants. Or Dr. Rivera, what's up, man? Yeah, so full mouth reconstructions essentially. As of probably March of this year, I'd say we went to a fully digital workflow. We've always been a hybrid of a digital and analog workflow. We kind of leaning mostly towards the digital, but as of the last piece of technology that we got, which is the photogrammetry, those little dominoes, if you've seen them posted on my, that's probably been the wild card. That's probably been the last thing that's like able to transition us completely into the fully digital world, you know? So, well, with this COVID, our clinical operations have stopped, obviously, and, you know, we're seeing emergencies only. But our lab is fully working. So we have one ceramist who's here all the time. He works in his little corner. And then our CAD guys are all digital. And so they're all, you know, working remotely, which has been really nice, actually.
Do they only work for you?
Yeah. We don't accept outside cases.
That's like our lab technician too.
Yeah. And you have Paulo, right?
Yeah.
Amazing.
Yeah, Paulo's
how different is that?
Pretty awesome. It's been a big change for us. I mean, it has been awesome.
I can.
You know, it takes a little bit to get on the same page with the ceramist.
Yes.
So I'd say it took us 6 months maybe to like make sure we were all aligned on everything. But then once you get into the zone, I can't imagine not practicing like this again.
Dude.
You know, having that connection. And for him too, he said how much he's grown since being with us because he never got to see his work in the mouth.
I know. That's huge.
Maybe in photos, but not in real life.
Yes. You know, that is a very underappreciated part of dentistry. When I was training, the technician prosthodontist relationship or technician dentist relationship wasn't very emphasized, but a lot of the programs and a lot of the mentors that I work with, that's like been their bread and butter, that they really rely on that. Like, for example, like right now, every full mouth preparation, actually every preparation that I do, will do, hey, Chase Kelly, what's up? Thanks, man. So Chase has actually seen this in person, but everything that we do, if I'm ever preparing a tooth, before I impress or anything, I'll grab the ceramist and they'll come down. Yeah, and so they'll come down chair side and I'll just get up and they'll sit in my chair and they'll grab a pencil and they'll put my prep, I have a prep reduction guide, they'll put my prep reduction guide on the tooth and then they'll literally just start marking, okay, this margin's too tall, this margin's too high, you're tapered here, you know, whatever. Usually my preps are like perfect, right?
Of course.
But no, yeah, I mean, they come in and they tell me what they need because they're the ones making it. And so, you know, I'm not shy about that at all. And no one in our office is shy about that at all. Because then when they get their work back, it's just so much easier for them, you know?
Well, it ultimately becomes easier for you too, you know? So selfishly, like us giving our technicians the ability to see that makes our delivery easier, less complications,
100%.
Aesthetics better.
Totally.
Yeah.
Totally. So, you know, that's been really nice. We're actually in the process of expanding now. And so we're looking at getting,
the photos of your office already look huge. I can't imagine.
I know.
Expanding. My office is like a little under 1,000 square feet.
Oh my. Well, I was looking at it today. It's beautiful though.
It's nice. It's just really small.
Yeah. Yeah. Well, I mean, in Arkansas, real estate is not like a limiting factor, right? So,
Right.
but we're growing in terms of adding more people on to our team. So,
Cool.
you know, we're looking at growing more. And so, you know, you especially, you know, really understand this is the importance of kind of getting systems down packed before, you know, adding anybody on. So,
right.
Because you guys have 3 of you, right?
There's 3 of us. Yeah. Mm-hmm.
What made you want to bring a ceramist on?
We always had this dream, you know, with Pascal Magnier being our mentor, he was like driving in the technician dentist relationship since the very beginning, because his brother is one of the best technicians in the world.
Right.
And so ever since we started training, we were always like working really closely with technicians. Awesome. And realized that even if, you know, your technician is in the same city or down the street or even in the same building, it can still be hard unless they're actually right there.
Yeah. It's so
and true. You know, with a lot of labs, it was, you know, 2 to 3 week turnaround time. We really wanted to make that quicker. And, you know, we're high end, low volume. So we wanted to just do any little advantage that we could for our patients. And that was it.
Yeah. You know, that's one of the struggles that we're working with right now is getting our, you know, getting our systems down, but really getting speed up, because like, you know, high quality is one thing, but getting getting high quality and making it fast, that's completed. Thankfully, you know, digital has obviously changed that tremendously.
Well, yeah, one thing that like my friend Miguel Stanley talks about is you do slow dentistry. Slow dentistry is kind of a general topic, but you want to do all your work up front so that you can do it quickly in the chair, right? Yes. So you're making all your decisions up front. You're not making very many decisions in the chair, right? I mean, very little, especially with implant dentistry. Yeah. So spend all your time outside of the chair. That's your cheap time, right? That's not your chair time. That's your time where the patient's not numb, bleeding, sedated, nervous. So that once you get in there, you've made all the decisions and you're just executing.
100%.
And that's how I always explain it in my lectures, because people are like, "Oh, does it save you time?" And I'm like, "No, I don't really think it saves me time. It saves me time in the chair, though, and that's 100%. Expensive time. And that's a time where the patient doesn't want to be there. The patient's like, do whatever you can while I'm at home."
Yeah, that's a time that you're not stressing over. That time doesn't give me ulcers when I'm sitting in my boxers planning a case on my computer. You know, I mean, that's essentially the whole mantra of my training when I first started was, you know, plan with the end in mind and do it all in low stress environment in your lab and wherever before you get to the chair. And I tell my you know, lab staff here all the time, like the better you can make your decisions up front and the better we can decide things now, that I don't want to think, I want to be just a computer. Exactly like you said, I just want to be a machine and just, you know, still make clinical decisions and critical decisions. But, you know, I don't want to be deciding, well, is my implant platform 1 millimeter apical on my 2 distal? I want to just have it planned before, and then I'm just confirming my plan versus executing and confirming and planning on the fly.
Yeah, well, that always bothered me when I first got out of residency, because we did a little bit of digital stuff in my residency. And then I got, you know, I was like working for other people and placing implants and things. And I just hated taking that x-ray and going like, that could have been more distal, or, oh, that's not deep enough. Or it was such a terrible feeling for me. And I went home and I thought about it and it drove me crazy that when I started implementing digital, I never had that feeling, you know, I never had that like, ooh, look at the x-ray. It was always just like, yep, that's what it's supposed to look like.
Nailed it. Yeah, exactly. Exactly. I mean, and there's deviations, right?
Yeah, and the things that I couldn't predict are like, you know, primary stability, or, you know, a buccal plate blowing out, or, you know, there's, like you said, there's things where you still have to make critical decisions, but it's much less critical decisions that we have to make.
Totally.
Oh, let's see. Talk again. Let's see. I can't hear you. Okay, we're back. So let's start with, let's try to go like start to finish, average, let's say, terminal dentition case. Okay, so we have teeth. We'll do an upper lower just for talking's sake. We have teeth. They're all coming out. And what's involved in your diagnosis steps?
Okay. So we have
data collection, let's say.
Data collection. Yeah, you know, I think that's obviously the most important part. So just to give you a background, obviously I don't come into the chair until after all the information's collected. And so they're really building their relationship with the team first. They're building a relationship with the front desk, with the assistants, with even the lab staff that are getting face scan data. They're building a relationship with the entire team before the authority figure comes in. Sure. And so that, you know, really brings down the barrier so that by the time, you know, the authority figure comes in, or, you know, the doctor comes in, it's a lot more kind of stress-free and just very relaxed. I'm never like crossing my arms. I'm always just coming in and, which is actually going to be one of the scariest things here with this COVID, because I'm very like open with my patients. So yeah, you're going to have to come in like a stormtrooper. And, you know, lots of my patients, especially cancer patients, we hug, we, you know, high five, and I don't know if we can do that anymore. So that's really scary, but, you know, not deviating. So typically there's a few things that I need. The first thing is we take a CT. We take intraoral scans. We take intraoral scans, CT, and face hunter information, or a 3D facial scan. Okay. And then FMX if needed. If they're edentulous, obviously we don't need one, and FMX or bite wings or whatever x-rays are necessary. And then perio probing or you know, depends if it's, you know, completely terminal and it's obvious, then, you know, we're not doing a full mouth probing, but at least some sort of perio screening. And then from there, before I go in, the first thing they'll do is take a CT, and I'll go look at it, so that while they're getting the data, I can at least maybe throw in some implants real quick, or, you know, get some diagnostics beforehand. Do you take your face hunter with them smiling? So let me show you actually while we're here. So I'm currently upstairs. Let's see how I flip this camera. Yeah, you're 2 floors. Okay, you don't have to brag. I get it. I get it. That's the elevator. Okay. Okay, so here's our photography room. Okay. This is what we're talking about with the face hunter. Let me turn the comments off so everyone can see. Okay, yeah, there you go. So this is what we're looking at with the face hunter. What it is it's essentially a digital face bow. So here is a little stand where you can lift this part up and down to the patient. And what they do, there's a level right there. What they do is they put their face, just like your regular face bow, they put that right there. And then they get to see themselves and align themselves left and right in this mirror. And once the patient's lined up in here, we put these little cameras in front of them. And so these little cameras have little flashes on them on the left and the right. And you know what, I think I have some screens pulled up. So those little cameras will acquire the face data, and then we'll merge the intraoral scan data with the face. Yeah. So let me show you here. So we're in our CAD center right now. This is our little CAD training table. And let me show off my talented ceramist that makes me look good. Kite, say hi to everybody. Hello. Stay 6 feet away, Kite. So I'm bothering Kite while he's working. But okay, so I'm sitting at one of these computers, and after we gather all the information, we bring it all into here. So let's see. So right now I'm on the again, I'm sponsored by this. It's called Zircon Zon. It's just one of the softwares that we use. So you can see this is a design. So this is way past the initial phase, but this is a design. But what we can do is bring in a face. And so you have the design and you have the face incorporated in it. So did you scan their face with smiling and not smiling? Yes. So part of our protocol is mouth closed, where you can see the mouth closed, and then you can actually turn down the transparency so you can see where the teeth stay relative to the lip line. And then you can do it with smiling. You can really do as many as you want. I typically will just do smiling and mouth closed. But if, you know, for those that haven't seen this technology, essentially what it does is it allows you to, if you think about your denture patients when they come in and you have to check your midline and move your cant and then check your occlusal plane and check all that stuff. Well, what happens if you don't get it right the first time? The answer is you send it back to the lab and you just bought yourself another 2 or 4 weeks in that case. And so what we are able to do this way is, you know, really limit the amount of times that we have to try teeth in, because you can change midlines, you can change cants, you can change really as much as possible. You know what, that reminds me, let me show you something. You can really change a lot of stuff before you even see the patient, before you're trying.
Well, this has been one of the biggest things with me going into full digital workflow and going into, you know, from Smile Design years ago, was making sure that aesthetically it's going to be perfect first. Now, functionally, we may still need to try something, or something may not be thick enough or whatever, but I know that when I put it in, it's going to look good, at least.
100%.
And so, that is, so again, all of that expensive time in your chair when you're, you know, bringing out the flame and you're changing the teeth, or even worse on veneers, you know, it's even harder on denture teeth. At least you can go back and forth, but on veneers or tooth-borne, I mean, that is difficult.
Yeah, exactly. And I actually always tell people that full mouth implants are much easier than a full mouth tooth case, because with the tooth, you're locked down to where the abutment is, whereas implant, you're not, right? So what I was going to show you is what that is. One of the things that we're, I can't really talk about the company, but one of the things that we're prototyping is moving the teeth and actually changing the lip structure, or actually changing the soft tissue around it. And so I have a, let's see if my computer pull up. Does it matter if I go horizontal or?
Yeah, we just have to go like this.
All right, I'll just go like this. So let's see. So this is what we're used to seeing, right? These are like static images. I was showing this to a few of my colleagues a few weeks ago. These are static images. You'll take a few pictures of patients, and then, you know, a static one and a smile, and then a edentulous one. And those are all fun and dandy. And, you know, your colleague, Kristen Coachman, has come up with just beautiful workflows on doing this just with iPhones. But that's still static imaging, in the sense that you can't really manipulate it and see how it changes. And so one of the things that we're starting to do is, instead of static treatment planning, or treatment planning people off of a face and then moving your teeth into where they should go and hoping that your lip support's the same. So what we're able to start working with, or hoping to be able to start working with, is what's called dynamic treatment planning. And so what you're able to do is take this static image and make it dynamic. So take this face, put your face in front of it, and animate it. And so what I'm able to do, that's the same image. I can move the patient's eyes, move her lips, teeth, make all sorts of funny movements with it, right? And so what it does is it turns that face into a wireframe image. And then by moving your teeth left and right, you can easily simulate where the lips should go. Kind of scary technology, honestly, that you know, this is out there, that somebody could take your face and, you know, make that happen.
And animate you.
Yeah, but, you know, it's really cool stuff in terms of what it can do for dentistry, you know?
Yeah.
And especially for maxillofacial prosthetics, where, you know, facial support is actually really important.
Yeah, well, it's so important. You know, we published an article with my research team showing how important static imagery is, and looking through video, and how much it changes lip lines and pose smiles versus dynamic smiles. And so, yeah, that is just exactly where everything needs to go.
Yeah.
Very, very cool.
Totally. I think that's exactly where we should be headed. So.
Okay, so you basically have, I always kind of say this, and maybe it's bad, especially if patients are watching, but I kind of think of like, you've taken the patient, you've cut their head off, taken it home, and now you have it in your computer, right? You can do whatever you want with it.
Yeah, that's exactly right. So beforehand, obviously, I don't think we have enough time to talk about the psychology of edentulation.
Yeah.
And, the psychology of full mouth treatment planning, because it's one thing to treat and plan the teeth, but to treat and plan the human attached to the teeth is, I think, a very different art. And so I talk about this in my lectures a lot, and I always say we're allowed to agree, but we're also allowed to disagree. And it's okay if you don't agree with somebody on them extracting teeth, and it's okay if you don't agree with them on keeping teeth. But what's important is that whatever you're doing, one, you're trained to do it, and you're doing it with your best intentions. But too many times, especially in social media where we are right now, is we see a lot of people seeing other people's treatments and not really seeing what goes on in the chair or what that person's circumstances are or any of the other X factors or the psychology of treatment planning these cases. And so it's kind of like a public service announcement of just we have to be very watchful that there's a lot that, especially on platforms like Instagram, you really get one picture or one carousel to show off an entire case. So there's a lot that goes on behind the scenes that we have to be kind of watchful for, if that
sure.
makes sense. So, but let's see. We were talking about.
So you've taken the patient, we've digitized them. Let's say, like you said, we won't go into the psychology. Let's talk basically like treatment planning and execution. So you've decided you're going to fully edentulate them, and we're going to place however many implants. And maybe to make it, to make it exciting, we should do like a FP1 on top and a FP3 on the bottom or something.
Perfect. Okay, so that's usually my goal. Well, my goal is to get FP1 on both arches, if I can.
Why don't you explain really quick if someone
you know what?
doesn't read the Bibles of Floss.
So the FP classifications, by prosthodontists, admittedly, they don't really accept that classification because it's not like in our prosthodontic terms.
Handbook.
But so here's, I just pulled up a slide on that. The FP1 classification is by Mish, and what he did was FP stands for fixed prosthetic. And so FP1 is a prosthetic where it's just tooth. Okay, so you have the implant here, and it's just implant. I don't know if you can see my mouse. It's just the implant, and then the structure that's on the abutment or the structure that's screwed down into the implant is just tooth structure. And FP2 is the same implant, but you can tell that now it's not just the crown of the tooth, but maybe a little bit of the root showing or some recession, but not a perfect ideal FP1. And FP3 is what we're probably most used to seeing, and that is where the implant is submerged, and then you have tooth form and gingival form on that structure. So you get both composite defect, as Bedrosian calls it, of both.
I was just going to mention that study that or that article that Bedrosian talks about, because I think it's really easy how he separates that. It's like tooth only defect or composite defect. You're either missing only teeth or tooth and something else.
Right,
and that's an easy way to separate it.
That's oftentimes the ones that are left out by our specialty organizations are the ones that are make the most sense. And so I think the Bedrosian articles are awesome in terms of just simplifying everything. But, just speaking of this FP1 and FP2 and FP3, I rarely ever do this. We have a lot of European colleagues that can get away with doing FP2s and get away with doing tooth structures. One of the people I look up to is Dr. Posey out of He does a lot of FP1s, and some of them come out as FP2s, and that's an acceptable result for your patients. But a lot of times what you see actually on social media actually is an FP2 or a really long tooth with no gingiva next to it, and it's touted as an FP1. So the whole point of
the ratios of the teeth aren't actually correct.
Exactly. And so the goal of something like this is to reduce as little bone as possible. And I know that's kind of the mantra that a lot of us are trained in full arch stuff. Well, you have to make sense, or you have to make room for the prosthetic so that you can have enough space for the prosthetic. Well, when I was first training, that just didn't make sense to me. it didn't make sense to me that we fit the patient to the prosthetic instead of fitting the prosthetic to the patient.
Yeah.
Right? And so it would be like your hip doctor saying, I'm going to need to take away about 1.5 centimeters of your hip so I can fit this piece of zirconia in there. But there's another way to do it, but you know, it's just not quick enough. I have 10 other patients in the back. So, you know, that wouldn't fly in,
yeah.
You know, if that was your family. And so I'm not saying there's anything wrong with it. And it goes back to saying that we're allowed to disagree, but that's just one of the things that I think I just inherently disagree with.
Well, it comes to the aesthetic too. I think it's so much easier aesthetically to do an FP3,
Yes.
hide the transition line under the lip. If anything happens, it still looks good.
Yep.
And FP1s are difficult, especially when you're talking about multiple implants. You know, you need to get highly scalloped gingiva to get the natural appearance, because we know that when we look at a smile, if the teeth proportions are correct, the first thing we look at then is the gingival architecture. And if that doesn't look natural and that looks flat, that's why you get so many of these FP1s that turn into FP2s.
Yes.
Because they lost papilla.
Nailed it. That's exactly
something that you do so well. And I love seeing when you post those photos of, you know, an edentulous maxilla with this beautiful architecture. And that is not easy.
Hey, sorry, I got a phone call there. It takes a lot of effort. It's not easy. It's just a lot of time. So like you said, it's easier aesthetically to just hack it away and hope that it's kind of in the transition zone or away from the transition zone. But not just that, it's much quicker to just make a flat transition space, like in these FP3s, and just screw something onto the tissue and allow for minimal pressure. But what we have to do with these FP1s is ensure optimal pressure in one spot. And then, you know what, let me pull out a case from our lab. So, you know, we have to ensure optimal pressure on one area and then relieve pressure where the papilla is, for example.
Right.
So let's see here. I'll pull out a printed prosthesis here.
So when you're planning your cases, what software are you using? I mean, for the implant aspect of it, let's say.
Yeah. So we've got for the implant part, for the surgical part, we use Blue Sky Plan, Blue Sky Bio. It's a free software. It's just super easy to use. My lab's just gotten really used to it, and it just works in our workflow. We have toyed around with other softwares, but honestly, it's free, and it's what all of us have used in residency, and it's just,
you get used to it.
You know, you just get used to it. But there's plenty of other great softwares. You know, like Nobel Clinician has their DTX software. There's Strauman's got great software. They all work. You know, people ask like all the time. A lot of the questions that we put up were, "What's your software? What's your workflow?" I don't care. It truly doesn't matter. But each of our lab people have their preferences. And so we have 3Shape, the full design studio. We don't have the implant workflow. Did you need me? Okay. And then we have Zircons on for design. And then we've got ExoCAD just recently also for design, which are very similar to Zircons on. But mostly because we hired a new team member, and he is really comfortable with ExoCAD. So
I think in implant planning software, the important thing is that you can plan the prosthetic, or you can bring in the prosthetic, because I've seen implant planning software that's just like put the implant into the bone.
Yes.
And then people will send me cases like, "Hey, I'm planning on placing the implant here," and I'm like, "Where's the tooth?
Where's the tooth?
Like, what do you mean?"
Right.
It's right in the middle of the bone. Well, that may not be the place where it needs to go.
So I just pulled out a printed prosthetic for you that we have. And so what you're seeing is...
So this is printed?
This is printed just like a prototype, just so you to see if it worked.
Got it.
But you can see that each tooth is coming out of where an implant, or each implant is coming out of where a tooth should go. And obviously, see if I can get closer, looking at the centrals here, you can see that there was no bone reduction.
Yeah.
Right? That little space in between 8 and 9, that's where we'll have papilla starting to grow. And so, you know, one thing I like to say, and I haven't, I've been trying to kind of think, because I don't really know many people doing FP1s routinely. You can, Posey talks about this. I don't know how to say his name. Is it Posey?
Yeah.
Yeah. He talks
about
this.
maybe they say.
Yeah.
They say Potsy. I think they say Potsy.
I'm saying an American Posey.
Yeah, that's okay.
So Posey says no. So he talks about this a lot, and he talks about converting flat architecture into scalloped architecture. And I've always thought that I agree with him. But you know, the best way to say it is when the tissue is like a beanbag. And so if you think about a beanbag that you sit on, if you have a flat beanbag and you sit on it, what happens on your sides? It goes up on either side, kind of hugs you. And so if you have a flat architecture on an FP3 and you put a pontic or somebody sitting on that beanbag, what's going to happen? The tissue is going to want to push down to the side. But if you put pressure everywhere, that beanbag is going to flatten out. And so when we're talking about ponics, you have to kind of pressure in one spot, but you also have to relieve on either side so that that beanbag behaves like a piece of liquid. I know it's kind of
the problem, I think the problem with that oftentimes is that you are raising your gingival margin and therefore changing the ratio of the tooth and making it longer. So you have to make sure that you're not making the tooth longer in that case.
Yes, and so that's part of the plan from the beginning. Right, and so in dental school, I was always taught, like, don't make the temporary too nice because they'll never come back for it. That's like absolute bullshit in real life.
Did I tell you I found an answer to that?
What's that?
You just pay up front. They always come back.
They'll come back. Right.
They always come back. Yeah. It's weird.
It's so true. It's so true. Well, I don't subscribe to that. I think the temporary is actually the most important phase, and I spend a lot of time on my temporaries, and that's why I post a lot about these temporaries, because especially for an FP1, if it's contoured properly, imagine you have this big flap, wide open, bone everywhere. How is that flap going to heal? Either by primary or secondary intention, right?
Yeah.
If you're letting it heal by primary intention, but you have like a flat architecture, that's one thing. But oh, look at the bob. That's cute. So if you have a temporary that's nicely rounded and the contours that you want, well, how's your flap going to heal? Probably by primary, but in the areas that it's not healing by, or in areas that it's healing by secondary intention, it's going to have to follow some sort of wound edge. And what's your wound edge going to be? It's that perfectly rounded temp. So if you spend a lot of time on your temps, the tissue just by default, I call it passive sculpting. You're passively sculpting the tissue. I rarely take a burr to tissue anymore. I spend more time on my temps to allow for the tissue to heal around that.
Yeah, that's exactly right. And I think the other thing with that, with making nice temps, is when you give your patient the final restoration, you don't want them to be like, oh, well, I don't like this, or I don't like this, or I don't like this. It should be like, yeah, it looks exactly like the temp, you know? And that's how I kind of talk about it with my patients too, is like, this is the same as your provisional, it's just stronger, and it won't stain as much, you know, like.
Yep. Exactly.
That's about it.
It's a different material. It's the same thing you're wearing right now. It's just made out of porcelain instead of acrylic.
And when you're doing the digital workflow, you can actually make it the exact same.
Yeah, that's very true. You know, so going back to what you're talking about, so we'll have our initial appointment, get all of our stuff, and then we'll plan our implants. How come Kyle gets all the hearts when he starts talking? That's not fair.
I think it's delayed.
Yeah,
or maybe it's the dog.
Yeah, it's the dog.
She's a class 3 too. We gotta fix her.
How old's the pup?
She's 7.
Oh, cute. That's awesome.
Butterball.
Cutie, Butterball. And why don't you just throw up what Butterball's Instagram is so everyone can see it?
Yeah, Butterball Bulldog. She's rocking skateboarding, bike riding.
Yeah. That's incredible.
So you plan your implants, you plan your prosthesis, and I should say that backwards. You plan your prosthesis, then you plan your implants.
Yeah.
You print them.
So, but you know, before that, I don't do most of that. So we have our lab team will do, you know, one of the life hacks that we figured out in this lab is that one of our team, you know, one guy we hired for our CAD team, has no dental background at all. He's a mechanical engineer, hasn't been trained in dentistry at all, but really knows the CAD world inside and out. Well, in our opinion here, our philosophy is that you can train teeth. I can teach you what the tooth numbers are. And in the digital world, they really don't have to wax anything up.
Right.
People way more talented than you or me have waxed these up and imported the libraries. All you have to do is move the tooth around. And so if you can comfortably navigate the digital world, that's more important to me than you being able to know what the mesial line angle of 9 should look like compared to 10. Right?
Just copy nature.
Just
take in the library. Yeah.
I tell them, don't
Those
touch
are natural
library.
teeth. So yeah, there you go.
Don't touch the library unless the ceramist wants you to touch the library. Just move the teeth exactly where they should go. And so they will actually, you know, the hardest part about all these plannings, not the hardest part, but the most time-consuming part about all these plannings is like finding the file, where is it on the server, import, and then line it up, and then line up to CT, and then click the button. It's like that's what takes the most time. And so that's what they'll do. They'll set up our case, and even though we're an in-house lab, we still have to have lab scripts because they're a separate entity, and you know it's a legal document. And so I'll write them a lab script, place implants in 3, 5, 7, 10, 11, whatever, and then have them place the implants, import the software, import the files, do all that for me, and then I'll come in and move the implants to where they should go. But that way I'm not worrying about like add implant, remove. Like,
you know. This is what I always tell too when I teach digital planning, you know, for implant companies and stuff, is you always get the older gentlemen, I should say, that are, you know, my dad's age, and they're saying, I don't know how to use this. I'm never going to do this. And I say, okay, find the assistant that is always on Facebook or Instagram. Who's the one that's always getting in trouble? And they're like, oh, Jane or John. Oh yeah. I'm like, that's the person who brings in all your files. That's the person who does your intraoral scans. That's the person who places your implants. You can be, even for a full arch case, you can do 5 minutes of planning, 100%. You know? And it's just going, okay, I didn't like it here. I want to go here and a little deeper. Okay, this one needs to be twisted, and I'm going to go a little more shallow, et cetera, et cetera. And you're adjusting, you're coming in with the biology aspect of it and making sure everything's good, and then just pressing go and printing or milling.
Exactly. That's the perfect way to say it, because usually it's the ones that are the defiant ones that are accepting that technology, right?
Right.
That's really the point. So the wax ups get done first. The prosthetics get done first before we get to that stage, right? So we get the, whether we use zircons on, exocad, 3Shape, whatever it is, we'll get the 3Shape file. You know what, I might have a case pulled up here. But yeah, we'll get the prosthetic file, and then from the prosthetic, we'll import that wax up back into the surgical plan. And that way, when I get to the surgical plan, all I'm doing is moving the implant into where the tooth should go, ideally. And if it's not, I'm planning my GBR or my grafting to accommodate for where the implant should go.
Let's go into a question, because this is a question that we got both now and that you got sent to you, is in that digital planning, how are you changing video? How are you adjusting the bite in that case, or analyzing that?
All right, let's go look up a case right now. So I don't mount initial cases. You'll see our lab's kind of a mess right now, so you have to excuse me, but you'll see we have articulators everywhere. Every station has an articulator there, but we don't mount initial cases. Really, we don't get to mounting until our final stages, where we're working on temps, or where we're working on porcelain.
Let me see if I can get rid of this question. This always happens. I bring up these questions and Instagram won't let me click off of it.
Oh, nice. I thought I was the only one seeing it. Cool.
No. Yeah, so everyone can see it, but the problem is that it gets in the way.
All right, I'll wait for you to do that, and I'll see if I can pull up a. Okay.
Yeah, okay, well, I guess you'll just have to show it above that.
Let's see. Okay, so
there we go.
Here's an articulate. So let me go back a step. we really
I
won't
could
mount
delete this.
until, let's see if I can close out here.
Can you close it?
No. Trying to like pinch it.
Oh, I just turned off questions. Let's see.
Comments.
Anyways.
All right. Okay. So
whatever. I
that's
just
fine.
have to show it above the question. Okay.
That's fine. Okay. So our initial. So yeah. So let me take a step back. We really don't mount cases until the final stages. Our initials are usually all digitally mounted. That has been a recent change. My mentors actually at the University of Maryland came out with a pretty comprehensive review of digital articulation, and one of the things that they found was the trueness and precision of digital articulation is there. Not only that, but the trueness and precision of opening digital articulation is also there. And so I have always found that if you open the articulator digitally, as long as you've gotten the right records to begin with, that it's pretty dang close, especially for temporaries. And usually I won't be opening a case and then delivering finals. I'll usually open a case, deliver temporaries at that new vertical, and then go to finals after the occlusion's verified, if that makes sense.
Right.
And
you're not testing it. You're designing it digitally, testing it functionally.
Perfect. Yep.
And then if everything's good, when you go to take your final restoration, your final impression, just duplicating it.
Exactly. So, as far as, so to answer your question, restoring video, with my cases, I'm actually finding that I restore video more often than I don't. Especially on full mouth reconstructions, typically there's some sort of vertical component that's been lost. And in terms of MIP and CR, if you go to the Dawson school or, whoever school of thought you talk to, there's thousands of, theories behind it.
Yeah, that's like talking about religion or politics.
Yeah, like the beauty of inclusion is that it's all theory. There's so nobody can tell you that they're 100% right because no one is right and everyone is wrong, right?
So you're adjusting it on your digital workflow. And how are you analyzing the face? Are you guys using cephalometric type of training? Is it more based on feel or just kind of how it looks?
So let's see. So here's a digital wax up, right? But let's assume this is not a wax up. This is like a upper and lower. And let me see if I can turn on the
actual teeth, let's say.
Yeah, let's see if I can turn on jaw scans. Okay, so here's the jaw scans. But let's say it's just the upper and lower and it's mounted. So in that face hunter that you were seeing, there's part of it that gives you a third point of reference because that's what the face bow is. It's not just a horizontal plane, but you also get a third point of reference with the face. And what we find with these cases is that, remember, we have this digitally articulated, but I also have a face scan. And so what we find with these face scans, again, this hasn't been manipulated or whatever. This is just typically that third point of reference. Hey, that's right where your face bow usually goes, isn't it? It's always in the same spot because you have to think about the basics. And so what are these articulators designed off of? They're designed based on averages. And so depending on what articulator you're using, like a Panadent, for example, is based on an average of 100 millimeters from your audience meatus to the A point, or it's a size of 8 and 9. And so it just so happens that those averages most of the time are spot on, right?
Yeah.
And so typically we'll just have their face. And if you have, let's see if I have let me pull up the other one that we had here. If you pull up their face, lots of times, if I can get to the articulator, lots of times that face actually has the rotation part of the articulator or the condyle right where the patient's condyle is. And so unless we're talking about an extreme scenario where somebody's born with a congenital defect, or where somebody was born with a cancer, or somebody acquired a cancer tumor or some sort of trauma, these averages are spot on every time. And I say every time is in 99% of the time. That's enough for me to adjust it.
95% of the time it works 100% of the time.
Yeah. And 80% of the time, I'm
Hey, I'm going to end this just so this question goes away, and I won't pull up the questions. I'll just say them because we're in 10 minutes, we're going to have to end it anyways. So let's end it and come back, and then we'll keep going.
Good. Okay.
All right.
Welcome back. Here we are with Dr. Sinada. Let's paste it in here. Let's post this. And pin this question here. And let's bring him back.
Naif is back. All right.
All right.
And we got rid of the question.
Let's see. Yeah, seriously. Now you can see my whole face. Here you go.
Okay. So you've
up
acquired data. Okay, great.
Here's the face, the one that we were just looking at.
Mm-hmm.
And look at that.
Mm-hmm.
That condyle. Again, this patient's pretty average patient, pretty moderate FMA, not like a high FMA. And that rotation or center rotation of your articulator is pretty spot on to where the condyle should be, right? Just anterior to the external auditory meatus, sometimes a little bit more superior. If we're off by a millimeter, or even sometimes with some articles, if we're talking about even being off by like 5 millimeters, can still be, because what you're trying to achieve with that is your axis of rotation. And so that's usually will be pretty close. It's like the second molar that you'll need adjustments on, right? And other than that, you'll be spot on with your vertical. So
okay, great. And I think this goes back to the importance of provisionals, right? Because we're kind of guessing at the beginning. We're verifying it physically, functionally, aesthetically, also with speech.
Yep.
And then because on implants we're waiting multiple months before we have this, it's like the longest test drive you can have.
Exactly. Yeah.
And if everything's good, scan it and go to final.
Right, because what you're saying basically is you're testing it on a real live articulator, which is the patient.
Exactly right.
That's the best articulator that we have, right?
Mm-hmm.
So, so I think that's a really important point that you just brought up, is that your temps should be very close to your finals. Your temps are essentially your finals, just made out of a different material. And not just for practice management, but just in terms of the dentistry, I think that's a really important phase to look at.
Yeah. Okay, so you have acquired data, you've designed a case. Let's say you design where the implants are going, you design where the teeth are going. Now you will print a guide. Are you milling or printing guides?
I've done both. Now I'm exclusively printing guides. Milled guides were actually really, really accurate. They're probably like the most accurate ones that we had. It's just you have to like waste the whole puck to do it.
Right.
Whatever is not a big deal. If it is the most accurate, then that's the most important thing to me. But it just wasn't very, you could print a guide and just be done with it in an hour versus like having to put it on CNC and calculate it and then mill it overnight and then so printing is just a lot less labor intensive. And so now we're just printing all of our guides.
Yep.
And then you can print multiple ones at once. So you're printing on a Form Lab, right? Yeah,
we have the Form Labs too.
How do you like it?
We liked it at first, and then we had a lot of problems with it. Yeah. Their customer service is terrible.
It unfortunately really is.
Yeah. So
you'd think they would listen to like lives like this and change their ways.
I know. Can we tag them?
Yeah.
Yeah. Between your followers and mine, there's a lot of people that will be seeing this. Okay. So Form Labs, get your shit together. Okay, so are you using metal sleeves in your guides?
Yes. I've tried pretty much everything. I've tried it without, and it works. However, some areas, especially areas of offset. So the offset is the distance between, I know you know this, but the offset is the distance between the implant platform and the top of the sleeve where the head bottoms out. Ones with really tall offsets, or where you have to modify the offset, by the time you're placing your implant, you've actually like worn down a lot of the internal part of the sleeve. And so I've just noticed a lot of slop by the time I'm placing the implant. And so it's not worth it to me to save, you know, a couple dollars on sleeves for a minimally optimal result, because the whole purpose of this, you have to remember, like you were saying earlier, is for you to spend the time beforehand, for you to save, you know, your results in the end. And if you're doing all this and then by the end you're still not getting an optimal result, then why are you even doing it?
Yeah.
You know?
Yeah, I've never done it without metal sleeves, but I've heard the same thing from what you said.
It works. You know, I'll definitely don't do the metal sleeves on the pin placements. Right. When I'm doing stabilizing pins. And the reason I don't do that is it's just one burr. And so you have one burr pin. So there's really not much.
And you're not going in and out and in and out and in and out. Yeah.
Right.
You're going.
That's exactly what you said.
Yeah.
So, you know, for that, I'll do it. But, you know, the sleeves are, you know, they are cost prohibitive sometimes, but it's worth it, you know.
I agree.
Going through this whole process anyway. But, you know, I do get that question a lot. But so we'll print the guides. And again, you know, I'm not doing it. Our lab team is doing it. And they usually will print probably 10 guides at a time. Let's say 5 guides at a time. You can fit more, it just takes longer, but we'll typically print like 5 guides at a time. Take about like hour and a half to print that much, and depending on how it is.
Are you doing that on a carbon?
Yeah. So, you know what? I think we have something on the printer right now. So, what we're talking about here is is this printer here. Nope, nothing there. But basically what it is it's a 3D printer. And then you put the resin in here. And what you see up here is the plate. So you're going to have basically this little plate goes into there, and it sinks all the way into the resin. And then it'll start printing and printing and printing. And then when it's done, you have your objects at the bottom of your plate.
Now, I think the most important question is, do you have the carbon shoes?
You are
right. There they are.
Of course I do. Are you kidding me? I'm such a sucker too. They just sent me an email. They're like, "Hey, we came out with some new ones. Do you want to buy some new ones?" I'm like, "No." And then what I do? I bought them anyway.
That's great. So we had a question. I'm not going to put the question up because it'll freeze everything. But are you using stackable guides or multiple guides?
I'm using multiple guides. Typically, I used to use stackable guides when I was doing a lot of bone reduction. So what you end up having is like, you know, one guide for a bone reduction, and then on top of it, you stack your implant guide. But I don't do very much bone reduction at all anymore. And so for that reason, I don't do stackable guides. But
do you have a guide to place your provisional so that you know your provisional is being placed in the correct position?
Yeah. So,
and do you use the same positioning pinholes for that, or do you go to the pallet, or?
Yeah. So to answer your question, I do try not to say do, but I do.
Don't do that.
I do. So, you know what? Let's go through. I've got like a case I've planned here. That's exactly what we're talking about. Okay. So it was what we were talking about earlier. We have our imported CT scan, right? And then you overlay your intraoral scans on top of it.
And you can see the scatter on the CT scan, which is very important.
So you can't build a guide on that scatter, right? That's exactly what Kyle's saying. You need to build it on these scans. And so this, to go back a little bit, this is a terminal dentition patient. You can see it's just the teeth are completely bombed out. Whether you agree with it or not, the decision that the patient and I both came with is that this dentition's not worth saving. And so
one quick question before you go on, because I know this is a little question that came up. photography in this photo. Do you have two big bouncers, or are the bouncers attached to your camera on this?
They are tiny little, they're twin flashes, and they're from Pixco.
Hey, I think we have the same ones.
Oh yeah?
Yeah, we do.
Yep.
Except the top thing broke on one of mine, so it's kind of ghetto now. But
what's that? Like this thing?
Yeah.
Yeah. That's for that reason. Actually, I Velcroed it.
Oh yeah.
I Velcroed it on both sides. But yeah, I use a mirrorless camera for chairside photography, just because it's lighter.
Yeah.
And it sits on a bracket with the twin flash.
Yeah.
And for these images, for most of them, I actually use a 50 millimeter. 50 millimeter lens. I know it's like, I would say frowned upon, but not many people use the 50 millimeter lens. I just think that with our, with the ratio that we have, it shows full arches really well. But this is the one I used in the clinic, mainly because it's so light.
I guess the only problem with 50 is that you can get some distortion, right?
Yeah, a little bit in the buccal corridors.
But you're not using your photography for treatment planning, because you're doing everything kind of in 3D. So it's more just look good, document cases. So yeah, it makes sense.
That's exactly right. The photography is mainly for communicating with that guy, and for presentations and stuff, and obviously for me learning. But then we also have this Nikon setup, essentially the same setup, but it's a full frame, and that's your more conventional.
Right.
This is a 60 millimeter.
We have that same lens.
Okay. Yep. That's a great lens. On a full frame, it gives you a little bit different setup, but what you'll notice, and what I'm showing here, is this is my aceramist camera. You'll notice it's the same exact camera that we have, and the settings are exactly the same. And there's a reason behind that, in that whatever pictures I take, I don't want to have to modify them and put them in his computer and worry that he's getting a different shade than what I'm getting. And so we just have the same exact camera. We use the same settings and everything. I think it's very important for whoever's listening to get in touch with your technicians or whoever's making you look good, and make sure you guys are on the same page.
Yeah. Okay. Thanks for the caveat. Let's go back to the case.
Let's see if I can turn this. There it is. Okay. So here's that terminal dentition case. Carries everywhere. She's actually a former heroin user or some sort of drug abuse. I can't recall. But she's been sober for 5 years and actually works a very important job now. And so she, needs her teeth redone.
Good for her.
Yeah. So, one thing I do is I take this same camera that we do. I take this picture, not for diagnostic purposes, but for patient purposes. And I believe it was Dr. DeWood out of Scottsdale that was telling me this. I can't recall who gave me this pearl, but they basically say to take this picture for patient purposes, because when you show a patient this picture, it's not an image that they're typically used to seeing. So just like when you look at yourself in the mirror, you're actually seeing your mirror reflection of yourself. And as soon as you use that TikTok filter where you like have it inverted, you're like, oh my God, that's what I look like. Yeah, that's what I look like to everyone. And so people, especially with terminal dentitions, when they're smiling, they typically don't show the canine view. And when you show them this, 9 out of 10 times they're like, that's me? Oh my God. I didn't know that's what I looked like from the side, because that mesial cavity on number 6 might not be showing from the front, in their other view. And so same deal. This is not a picture for me. I already have all this information on the intraoral scan, but this is just for patient purposes. And in this presentation, we kind of talked about would you keep these teeth or not, but we'll kind of avoid that step. So let's go to kind of like the workflow that we were just talking about. So you have your CT, scatter everywhere, but your intraoral scans are imported and they're overlaid. And then for the maxillary implanting, she has, I'm sure lots of you have seen patients, whether you're a specialist or a generalist, you've seen patients that have decay everywhere, but their bone levels are perfect. Or you have patients that have awful decay, but their bone is just like wiped away.
Yeah.
And so that that is part of what goes into our treatment planning process. But in her case, is decay everywhere, but literally bone levels up to every CEJ, right? Their bone levels are perfect. And so the goal here is to do what's called the FP1 that we talked about. And so to dentulate these teeth, this scan is kind of deceiving, and it makes these teeth look real nice and healthy, but every single one of these has pulpal involvement, right? So what we'll do is we'll import the pre-op scan, and then I'll maintain strategic teeth. And what I mean by that is you'll see here I have number 4, 6, 11, and 13, and they stay in throughout this whole process, okay? And so here's our strategic teeth. And then I'll digitally extract the teeth. And this isn't like arbitrarily extracted. You can see the extraction sites are like ovated, right? Yeah. And so that's how I want my prosthetic to look. And so this is actually what I build my prosthetic off of. So I digitally extract teeth, set that aside. And so since on this scan, my palate, see all this rugae, all this information here on the buccal, if I could rotate this, there's all this redundant information. Well, the wax up that's done digitally is done on that same file. And so what we use is the palate, the buccal, all that information to overlay the wax up onto that surface. And so that's how we know we're maintaining our accuracy or our reference points, right?
Someone was asking what program is for this. I think it doesn't matter what program it is, but it can be exocad, it can be 3Shape, it can be...
Yeah, so this particular one was waxed up on Zirconzon, and this is all done in Blue Sky Bio. But that absolutely does not matter what software you use. It can be done in all of them. And then since the wax, so here's our wax up model, which is basically the model with the wax up on it. And it's just teeth, there's no denture, there's just teeth and all this redundant information. At that point, I can extract the wax up part or the teeth, and that's what my FP1 is going to be made out of, right?
Yep.
And so this is what should be milled or printed, right? But typically I'm milling these. But now if I were to do this, can I reference this in the mouth? And the answer is absolutely not, right? Because it's just going to be like a floating little prosthetic in the air. Yeah, and so you can't really reference that. You don't know if you're going to move it left or right, etc. So what I do, the reason I do this first is I just need to determine the tooth position. Because then what I'll do is after I have the tooth position, then I'll place the implants. The implants are going where the teeth should go. Notice these emergences are coming out right of where this premolar is coming out where the central is coming. And I've tried different configurations. This is an earlier case that we've started working with, changing positions, but we won't get into that part. But again, I plan my implant depths accordingly with multi-units, etc. But again, I can't reference this yet. And so remember that first one where I had my strategic teeth maintained. The reason I maintain those strategic teeth is because I like tooth-borne guides. And so because they're just so much more accurate. And so I don't like to do these teeth, these soft tissue borne guides if I don't have to. And so I placed all the implants everywhere else that these strategic teeth weren't. Okay. And so there's my wax up onto my gingiva. And this is what you were talking about, Kyle. The reason I brought this up is here's pins. These are pins placed in the palate. They're not implants. They're just going to basically lock down my guide. And if these are going to lock down my guide, they can lock down my temp too, can't they? Right? So what I do is I basically just paste a little reference marker on the palatal. And now I have a palate with a pin. And now this can be intraorally referenced, right? Exactly. And so you have your diagnostic, surgical, and prosthetic all in one page. So the beauty of doing this completely digitally is that you absolutely just can't get all that information in one screenshot in the analog world. You would have had to have 5 different models. You'd have to have a putty index. It's just not possible. And so now I have them. Typically how they have it for me when I come in to approve the cases like we were talking about is they'll just pull the screen up. And this gives me all my information. I'm like, oh, I'm going to move this. I'm going to tilt this. I'm going to move this. Get my pin here, etc. Make sure my pin's not interfering. All that good stuff. And so that's kind of the beauty of it, because then I can reference this exactly to where, to where it needs to go. So that this one was in an early stage. We actually printed this one.
Okay.
And this is just kind of showing this, just a video showing the blue sky workflow.
Mm-hmm.
Yeah. I don't think we need to see that. But the final result is actually on the case pin right there where we were sitting. So I'll grab that. But one thing I do want to point out is that I do this. So I call this the Holy Trinity. Okay, this is what I need for every case. So I don't start any case in our clinic without a surgical guide. So all of our implants go guided, and which is the only way to go. And that's why I love what you do, Kyle, because it's precision, and it's thinking about your end result before you get there, right? And it's just as a side note.
Yeah, this is why we bonded so much, because we have the same philosophies.
We're such geeks. And we
like similar cars too. Yeah. Great FP1, just like totally nerding out.
I was having this discussion with I can't recall who it was, but anyway, they were like, well, what about the accuracy of a surgical guide? And that conceptually, that question drives me crazy, because the accuracy of not using a guide is I thought, no robot of a human can place an implant exactly where it should go. No guide can. Sometimes it will, but
I think that question comes from guides from 5 to 10 years ago. Because you probably were doing guides before we were mirroring the intraoral scan, like the double scan protocol.
Mm-hmm.
And they didn't fit as well.
Yeah,
that was just how it was. And I remember at that point, people were like, "Oh, well, what's the accuracy of this and that?" But as soon as you go to tooth-borne, full digital workflow with the guide, I've never had one that
Yeah.
rocks. And people are like, well, won't it rock? Well, it rocks if you take a bad impression, or it rocks if you have a shitty something printer was off with the printer, or something like that. But otherwise, I mean, you're just duplicating things.
Yep. That's it.
And that's now, when you get into tissue-borne, I think that's another question, and that brings up more questions. But
I still think there's creative ways to get around it.
For sure.
And I would still take that over
not having one.
Yeah, I'm just not that good.
Yeah, same.
I haven't met anybody that's that good.
Yeah.
And think about your most accurate snipers are still, they're trained to do it just like we are, and they'll never hit the target 100% every time.
Mm-hmm.
They'll get really close, which is fine, but in full arches and with these FP1s, really close is not enough.
Yeah.
I want precision on top of just accuracy. I want to hit that target or be close to that target every time.
Well, and that question may also come from people that only think about the surgical side, right? Because if they get the implant in and it's a millimeter off, it doesn't matter for them, because if the provisional breaks or the final restoration fractures, they don't have to deal with it.
Yep.
But when you're either doing both sides or you are part of the team, really, then you understand how everybody gets to a better outcome. The patient gets a better outcome, longer lasting, by minimizing that millimeter at that point.
That's a really good point. But I would argue that the surgical team has a lot to gain out of using guided surgery. Local colleague of mine, an oral surgeon here, was giving a lecture and showing one of our cases that we used a robot for. And, the biggest thing with this robot is marketing for referring doctors. There's no discussing it. Like, this implant went exactly where it was supposed to. Like, to the micron. Like, it's exactly where it is. There's no, well, I got this back. And surgically,
totally true.
Surgical partner, you're like, sorry, man.
And you probably get the same thing, because I teach restorative doctors and I teach surgical specialists, and they both complain about each other, right?
Yeah.
So the surgical specialist says the restoring doctor doesn't know what they're doing and they screwed up my implant. And the restorative doctor says, well, he or she didn't place the implant where I want it to, and now I'm struggling, and blah, 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 blah.
Exactly. Yeah. it's the blame game. That's so true. You know, unfortunately, we're not as a profession, we're not as good of team players as we like to think we are.
Yeah.
You know, but you know, it's absolutely right. It's really all about communication and just like, what do you want, like your family member to get? Not that there's anything wrong with not guided surgery. It's just, if I have the option to go guided, I'm going to go to a clinic that does it versus that doesn't, you know? So, okay, so let's just go back to this Trinity. I do a surgical guide for every case, a temp, an immediate loaded temp with holes for the implants, and then what I call the backup temp. And
are those Sinada holes I see too?
Yes, they are. Well done. Well done. Great. What a great pupil you are. I'll have to link that back here at the end. That's great. That's awesome. So these are the pins that we were showing earlier, where it's like pins in the palate. You know, this is all rudimentary for you, Kyle, but you know, just to show, these are pins in the palate that are just fixating the guide to where it needs to go. Now notice, this is like a belt and suspenders. There's a tooth here to stop this from going anywhere. Now, if you think about it, you have a guide that's like a denture. What happens when you deliver a denture? It's like spongy. There's called the relapse effect. Tissue has, I should probably know this, but I want to say it's like 0.4 or 0.6 of a sponginess to it. And so if you think about that from anterior to posterior, you might be spot on the anterior, but if it moves down, now you're way off the posterior. And so when you have a tooth, that's a hard surface. You put it down on a hard surface, there's no moving it, right? And so on top of that, I also have pins in here that are stopping this from moving. I'm a huge fan of pins because it's hands-free. It gives you one extra hand to be able to use you know, with your assistant or etc. So I place my implants through the guide. These are not implants, these are just the pins, but I always place my implants through the guide unless there's a really good reason not to. I'll usually go fully guided with the implant. And what I mean what I mean by that is that the implant itself goes through the guide and not just placing your burrs and then taking your guide off and then relying on your hands.
Well, the problem that I see with so many people that are doing it the opposite way, so where they're doing, let's say, fully guided drilling and then placing the implant freehand, they oftentimes place it too shallow, and then they lose bone and tissue, and then there's this whole, oh, well, every implant loses bone to the first thread. Well, not really. This is why you plan it at a certain depth. And I think what happens is you start getting some resistance and then you stop. And that may not be the full depth that you need to go to. And most implants, in my opinion, are placed too shallow.
100%. And you know, that might be happening with like a Nobel Active, which is a great implant.
Yeah.
Let's say it directs you to an area that you weren't planning on going, maybe the extraction socket, and you bottomed out too soon, right?
Yeah.
That's a great point. Would you rather a shallow implant or a improperly placed implant, but plenty of restorative space?
Well, that's a difficult question. Shallow implant, how thick is the tissue?
Let's say you have number 9. Let's say you have number 9, and the implant is placed right at the CEJ versus an implant that's placed, you know, 3 millimeters apical, but it's a little bit facial.
The deeper one, I would say.
I would 100% agree with you.
Yeah,
because I think it's easier to fix properly placed in terms of depth, but shallow implants, good luck prosthetically.
Very difficult.
You're good friends with Tomas Linkevicius, and you know, you need the space.
Yeah.
You need to be planned properly because otherwise tissue thickness is not.
Yeah.
You know, I mean, lots of other factors, but you know, tissue thickness is one of them.
Yeah.
But that's one thing. I think what you're bringing up is that was one thing about these placing it through the implant is that you're bottoming out exactly where you plan to go.
Yeah.
So again, with these FP1s, you don't really have the room. Like if you look at this prosthetic I just printed here, these are all at the proper positions that they're planned on beforehand, and you can't really have one in one level, one in, you know, in the other level. And so, if you remember, I had these key teeth that were in those guys. The reason I do that is quite a few reasons, but I have my guide with teeth and guide with implants. And what I'll do is I place all my implants in all the other areas. And so you see, I still have tooth number 4, 6, 11, and 13. What this allows me to do is place my implants. And then if I got great primary stability on all my implants, well, then I'm taking out the rest of the teeth. Or actually what I'm doing is root banking. But for the most part, theoretically, I'm just taking out the rest of the teeth. But let's say I got to the stage and every one of these implants was a spinner. Well, what I can do now is I don't have to give them a denture. I actually just prep 4, 6, 11, 13, and they get a roundhouse provisional. And so I call this decision time because that's the point where I just stop and we say, all right, we're going to load or we're not going to load, right? And in this case, we did decide to load. So having the teeth kind of gives you like a game plan. And
so this is one of the great advantages of your training and doing both the surgical and the prosthetic side is you can make these decisions right here.
Right, exactly. Yeah, thank you. But you know, that I think that's a very valuable part is making those decisions. Actually, I never really noticed this, but if you look closer, implants are placed right into the septum because of guided surgery. They didn't slip into one or the other.
Right. That's one of the reasons to place it through the guide too, is you can have the perfect osteotomy, but then as you're placing it, unless you have that resistance from the guide, it's going to go to the path of least resistance, which is usually buccal.
Completely agree. Completely agree. So here's our pre-planned prosthetic. Theoretically, these holes should be exactly where those implants are. And if you look at it, we're pretty dang close. Like that's exactly as planned. And so the game changer here is getting a little bit creative. And so this is what we're able to do. There's no book for this. People ask me like, what's the resource or what's the article? I don't know of any articles that do that. But what you have to do with this digital technology and just in the era that we're in, you have a problem. How do you solve it? And so I want my temps to be in the proper position. Well,
I think there is a new article coming out from David Norrie from Belgium about this.
Okay. Right. Yeah. David Norrie.
Yeah. N-O-R-R-E.
Okay.
Yeah.
And he talks about reference prosthetics.
Yeah. With using palatal pins.
Nice. Very nice.
I don't think it's published yet, but it's coming soon.
Love it. I'll look out for it.
Yeah.
Do you know what journal?
I don't know. He recently posted something and I messaged him about it.
Cool. Okay.
I'll get it when I get it. I'll send it to you.
Please. Yeah. So you know that's what you're talking about is this pin is in the same position because remember back with rewind a few minutes ago we were talking about the all the surfaces are correlated, right? So remember we had like this surface and that's lined up with this surface. So technically this pin here should be in the same position as those temps. And so why not use that to index your temps? And so that's exactly what we did here. And so let me go here.
Yeah, and this was so hard for me when I was first doing, all on X kind of treatment was implants placed fully guided, but then you go to do the temp and it's like, I mean, even if you have a palate,
exactly.
Even if you have a palate, it's still like,
it's still kind of moves.
And like you said, you can change the occlusion so much, and then you're just adjusting occlusion for 2 hours at the end of an 8-hour day, and it's just like
right. And then you end up with like
difficult
flat planes, and you're like, all that work,
right?
This final result, right? Yeah. Like that's like it happens to everybody. I mean, it's a fumbling on the 1 yard line. It's like, oh, got all the way here. Like, oh my God,
so close.
It's so close. And so, I'll fast forward through this, but this is basically what the immediate temps look like, right? And we'll fast forward. Actually, her case is actually on the pan there. We'll pull it out. I lost this implant here. Number 9. But, I end up keeping, I end up planning a lot of implants for these cases. I don't typically resort to all on 4 for FP1. And not 4 implants. Basically, I rely on more implants. So if you think about it, it's a weaker bridge. I can't remember. It's like the law of beams, which basically says that the longer span that you go, the thicker you have to be, right? Because the beams will flex. And so for that main reason, on these full arch FP1 cases, I'll never just do 4 implants. I'll usually break up pontic spaces into 2 typically at the most. On her case, she's got 3, I believe. You know, it makes me nervous, but the thickness is there. So
yeah.
So here's her. Just that same case. Let's see. So you can see that, you know, the intaglio. Try to pull it up here. Hey, you can't really tell, but basically it's a scalloped surface where in these interproximal areas, in these interproximal areas, like right there and there, the tissue is going to fill in. That's exactly what we're shooting for.
And so is this full contour zirconia? Is there any cutback?
There is a facial cut. That's a great question, Kyle. There is a facial cutback. And let me see if I have our model here. So we mill out these wax prototypes. And we mill them out in wax just to verify that everything's exactly where it should. But let me see if I can show you the cutback.
Oh, yeah.
So it's an incisal preservation.
Yeah.
So we don't cut back the incisal. We only cut back the facial.
Yep.
And so that kind of preserves the integrity of the incisal structures. And so that one is a facial cutback of, Kite, was that 0.5 millimeter cutback?
Yes.
Yeah. So we do about 0.5 millimeter of a cutback.
Yeah.
And it's just on a facial, so that hopefully we get as little chipping as possible.
Nice. Yeah. Very cool. There's some questions, and I'm not going to pull them up. I'm just going to tell you.
Yeah.
People are asking about which printer we recommend. I only have experience with the Formlabs, and I think it's okay. I've heard good things about the Moonray. I think if you have the volume like you do, you know, there's nothing better than the carbon.
Yeah.
I think one of their reps was telling me that their printer is working and functioning like 98.9% of the time or something like this.
You know what the best part about them is the service. They call you, you're a partner with it. When it's not down, we get emails and we get phone calls saying like, your printer's down, what's going on? You know, that doesn't happen with other printers.
Yeah, I've heard that like they'll even come in and you'll be like, what are you doing here? You'll be like, it's working fine. They're like, yeah, but in like 12 prints, it won't be working fine. So we're going to fix it now before it starts.
Yeah. And if it's ever down, they're actually contracted to come out in 24 hours. So
love that.
Yeah. So, and we're in Arkansas, we don't have anybody here. So they have to fly out.
Oh, wow.
To come repair it. We haven't had that. We haven't had the need for that, but we've had failed prints where we get an email. Again, I'm not sponsored by them. I just truly love the company. I've gotten correspondence being like, hey, that last print that you think failed, and we've noticed it's your second print. Is there anything you can help? We literally send them the file, they repair it, send it back, and it's prints.
Wow.
Okay,
so a few questions. How about this one? Are 2 pins on the palette adequate?
Yes and no. So, no. If we're talking about the implant, are we talking about the implant guide or for the prosthetics?
I'm guessing they're talking about for the prosthetics.
Yeah. So 2 pins are adequate, and the reason I think is 2 pins are adequate is they need to be like
in different ways.
Yeah. So you place it where you should be. You notice, like I said, it was like a belt and suspenders, and so.
You already have a vertical stop on the tooth. Exactly. So you're trying to get a horizontal kind of angled stop with the palate.
And the palate. So I have horizontal stop.
That's true.
And the tooth. And then that just fixates it to where it's supposed to go.
Yeah.
But if you think about it, I'm always thinking of like the weakest link. The weakest link here is first placing those pins. If you place those pins first in the wrong spot, everything else that you do is now in the wrong spot. And so that's why I'm always like kind of making it for myself. That's why I have like 10,000 guides, is because my first guide
is literally just to place those.
Yep. I haven't even taken my teeth out. I just put those pins in. So I have a separate guide, just sits over the teeth, put the pins in, and then I throw it away. And that costs in resin costs maybe 35, 40 cents in resin. Yeah. So it's like, I just throw it away. It's
Right.
totally worth the accuracy of it. But here's an image of the occlusal view. There's your pins right there in the middle of the palate. The reason, so we do pins. I've done pins on the palate. I'm not a huge fan of these pins on the palate. I actually like to have pins on the buccal and the facial surfaces. So I have them like sticking this way.
Free retractors.
Exactly. That's really all it is. Yeah. Is like free retractors. Yeah. But the main problem that I've found is that when we're milling prosthetics or guided prosthetics, the mill can't mill teeth this way and go back and mill holes this way. And so we've had to actually get creative. I'm publishing a article on a workaround with titanium.
Nice.
So
someone was asking how uncomfortable are the palatal pins. I found that my patients don't complain about them.
No one's ever complained about it.
I mean, you took out however many teeth, you've placed implants, there's sedation. They usually don't notice it.
They don't even notice it.
It's not like a tissue graft. It's much different.
No. It's like
it's bone pain and not tissue pain, and bone pain is much less.
Yep. I don't ever have to suture it. It goes in, comes out. There's no.
Okay. Someone says, are you concerned of losing some papilla in the future in the pontic site or recession?
For an FP1.
Yeah.
I am a young doctor. People way more seasoned than me can answer that question better. But I think the literature of Pozzi speaks for itself. He's been doing this for decades, and he shows that there's stability long-term in this. Now, it's not just if you just throw a pontic on there. There needs to be the right amount of tissue. There needs to be the right amount of space maintenance to maintain it. But literature, long story short, literature shows that it is maintainable. People like my mentor, Dr. Tarnow, will say that tissue and bone always wants to go flat. And so I was always torn with that. Like, I don't want to be doing all this right now and then come back in 10 years. That is that looks awful. Because I'm doing this on high smile lines, I'm doing this on low smile lines, I'm doing it everywhere. And so one of the things that I've incorporated recently is just root banking. And what that is basically those strategic teeth, those canines, those laterals, those centrals, whatever they are. As long as there's no periapical pathology, I'm just going to cut it off and leave it there.
Same.
And it's been a game changer, like truly a game changer.
Yeah, and I think that dentistry is going towards that now. I think it's catching on, with partial extraction therapy or socket shield. That is a really nice trend, and also with root banking. And it's nice to see that you may be edentulating the patient completely, let's say from their crowns, but we're maintaining the root and maintaining more of that bone, better long-term stability. You don't get that contracture.
100%.
100%.
So let me see if I can pull up what you can kind of accomplish with a root banking. Is really the architecture of the tooth architecture kind of stays there. Let's see here.
Yeah.
So this is just kind of an immediate post-op.
Someone was asking, do you need to endo-treat roots? No, you don't.
No, you don't. You don't at all. And that's probably the biggest question. I have a highlighted story. I'll probably share it again for you guys to see. But so where this started is in the 50s. This guy named Goyer, actually before Goyer, in the 50s, they started it's called the roots emergence technique. They were doing non-vital root banking or non-vital roots emergence. And that's because when you extract a tooth, you have to do an immediate denture. And then back in the day when you had processing errors and all that, they were trying to find ways to go around it. And so they were just doing endos on these vital teeth, especially on the mandible, and they would cut off those canines and do endos on them. And they're finding that, oh, this actually works. And so this guy named Goyer, I think it was 1957, started doing the same thing, but he's the first human study that was out there. And what he did was started just cutting teeth off and not doing not vitalizing the tooth, not doing endo. If you think about it, the hardest thing for us dentists is like, oh, periapical infection. But if you break a root tip, now you go back in and endo it. right? If you break a root tip and it stays there, or you've seen patients that have broken root tips, it stays there. Or, you know, for a better example, coronectomies for third molars.
I did a lot of coronectomies, and everyone told me I was crazy when I was doing it.
Leave it, right? And, you know, it depends on who you read, but some endo literature will actually show that there's a reparative dentin bridge that forms, and the root actually stays vital. And so amazing. But it doesn't hurt as long as there's granulation over it, because that's what, well, is it going to hurt the patient? It doesn't hurt. When you break a root tip and it stays in the mouth, is somebody like, oh my God, my root tip is hurting? No, you never usually have to fish for it. I mean, you want to anyway, but that's not, you know, that's never a chief complaint that, you know, patients complaining because of root tip.
So someone said on your FP1s, are you doing implant level or abutment level? I'm going to guess, but I'm going to let you answer.
No, I think, Kyle, you know that you're probably, you're way more in tune with the research behind it. But as much as I can, I'm going abutment level.
Yeah. And I think from that standpoint, accuracy wise, much easier. And the other thing is biologically, you basically have a one abutment. Whoa, just move that down. You have a one abutment, one time concept on all of your implants. So you get that hemidesmosomal attachment to your abutment if it's a good material, which it probably will be. It'll probably be titanium, and then you never remove that. So you have prosthetic flexibility and the ideal biology. So in my opinion, I think that's why the research on all on 4, all on X is so good. You know, not a lot of these implants lose bone over time because we're not taking things on and off all the time. 100%. And if you're at abutment level, you can take it off as much as you want.
Yeah. So if anybody's done these full arch implants, you know that if you ever had an implant case and you take it off to do whatever records or to even put your verification jig back on, it's a nightmare unless the patient is numb to take your wax trim off or whatever you're doing, putting it back on. They're like, ow, ow. And you're like, oh, one more turn. And then you turn it and you go back to, just 1/4. It's just, right? And what you're doing is squishing tissue and you're like ripping attachment or whatever it is. You're not operating at a abutment level. It's the same thing as like, you know, going subgingival on every single crown prep you have.
Right.
Squeeze your temps back on. I know, I completely agree with you. And I think the zero bone loss concepts support that, and I think that's probably the coolest new literature that's out there, coolest new book. Obviously Tomas has been doing it for way longer than this book. But I think that's probably the most exciting thing that I've seen out of him lately, is because it's getting a lot of publicity and
finally people are listening to the stuff. And it's funny, I've been talking about and showing his research ever since he started, and people would tell me I was crazy. You place implants below the bone, you're insane.
Put a healing abutment and then close the healing abutment over
And so it's cool that like people are starting to accept and see him for really the like genius that he is.
Totally.
And we've got some cool research that we're working on now that
and are you guys still doing your course together?
We are, yeah. So we have courses. I mean, I say yes, but you know, who knows? We have courses in September in Beverly Hills, and then in November in like Miami Beach area.
And where can people find out more about these courses?
My website, just drkylestanley.com. Yeah. So with that, we do zero bone loss concepts with Thomas, and then we do a day with me of how to apply that to the immediate workflow and also to the digital workflow. So kind of, because a lot of, you know, when he was doing a lot of his research, a lot of it was analog. And so bringing that all kind of into the digital workflow, how to plan it with like a zero bone loss concept in mind. And that was really the goal of us doing stuff together. So I'm just really excited to work with him. Such a cool guy.
Because that's taking like guided surgery to another level.
Yeah.
And I think that's the important part, is finding out not just where the tooth should go, but now we're talking about where the implant platform should go relative to an abutment. That's the goal. Right. That's pretty.
Bring in everything we know about materials into the digital workflow. So yeah, really cool. Let's see what other questions we have here. A lot of thank yous.
Oh, right. Awesome. Thank you. Thank you guys for tuning in. But, you know, notice here, this is just scalloped from the temp. All this is scalloped from the temp. Not one point in here did I ever take a burr to the tissue. This is two temps in. before final placement. But all this here, you see this width that we're gaining here? This is all because there's an actual root inside there. If you think about a root being in there, no root ever resorbs because the dentin's not just going to resorb away. And if you've designed it properly, the bone is not going to resorb away either, right? And so this will permanently stay there, this architecture, unless
really
we're
nice.
talking about something else. In these, and if you just compare, so this is a great view, and this is why I take so many pictures. Is just I noticed this stuff later. I took out the central incisors. Look at this architecture compared to this robust architecture. This is nice and fat. Granted, it's a canine, but look how much more resorbed this is versus these socket shielded and this root banked. It just, it speaks for itself. You do one case and you look at, look at the stippling up here, right? And here's a socket shielded implant and here's a canine root bank. This is positive architecture so that by the time the prosthetic is placed in play, let me see if I can find a picture of the, here we go. By the time the prosthetic is in there, it looks like it's emerging.
It looks like real teeth.
Yeah, like if you're looking at this canine, it looks like it's coming out of the tissue.
Still having canine eminence there.
Exactly, because there is a canine eminence.
Yeah.
Yeah, that's exactly it. Now, this lateral is a little bit deficient, but I would be okay. I would be happy with this.
But
result.
My natural tooth lateral is deficient like that.
Exactly. It's facial flow. That's exactly what I'm
saying. That's right. That's right. So we have a good question. Maybe we'll take a few more questions. Okay, good question. After studying zero bone loss, do you think all multi-units should be 3.5? I would say no, I don't think they need to be. You can think about it kind of as a tie base, and it depends on where the implant is placed on the emergence profile. So we need our multi-unit platform to finish above the bone. That's number one. But one of the ideas of maybe even having a shorter multi-unit is to have more space for polished zirconia. Yep. So I don't think they all need to be long. I think that maybe err on the side of long in the sense of that you'll keep all the attachment. So you're kind of going with like better material, more attachment, and aesthetics all at once. So I don't know if I have an exact answer for that, but
just to take it one step further, I think for full arch, it's completely different than for single teeth. Biology is the same.
Yep.
But I rarely go 3.5 for a full arch, and mainly because on these FP1s, I want them to be, which blows people's minds because the concept just don't get it. But I want a subgingival multi-unit, and so I want the tissue to be. I don't want that multi-unit collar to be super gingival. I want it to be subgingival, if anything. And lots of people just don't get how that can happen. But just that same one that I'm showing you, that's a subgingival multi-unit, and that way your FP1, you're not seeing like a tooth and then a metal. And so usually I'm between 1.5 and 2.5, but 3.5 just eats up the space. And if it's a thin tissue biotype,
sure does.
You're going, you're going to be you're going to be recession.
Yeah, because even if you have a 1.5, I mean, let's say you place it at bone level, which probably doesn't happen very often in immediate cases, but let's say you do, just for argument's sake, and you 1.5 multi-unit, you've already gone through this very small amount of connective tissue. You're already in epithelial attachment. So I think that may be enough. You're above the bone.
Yeah, right. Yeah, I think that's a good point. That's really the key, is being above the bone.
Okay, let's maybe do 2 more questions. Hygiene protocol. Are you removing prostheses to clean?
Are you?
We used to, but now not much. Not much. I think like the ones that we are removing now are ones that like were done a long time ago or were done before we changed our designs.
That's I'm the same exact way. What changed it for me was the American College of Prosthodontists, the ACP released a position statement, because that's a very common question, is do you remove prosthetics for maintenance and hygiene? And if you do you replace the screws? Do you place the same ones? Do you put new screws? And if you've ever
we used to.
Yeah, and so if you've ever placed these multi-unit screws, they're tiny little screws, and you're taking them on and off and on and off. You know, it's for 10 years that you're going to snap something, right? So especially if you're torquing them back on. So the ACP released a position paper, and led by, I believe, Dr. Pedro was the committee leader on that one. But they basically said that you don't take off your full arch prosthetics unless there's a need to. And what qualifies as a need is inadequate prosthetic design, like a ridge lap or some sort of, you know, something uncleansable, or dexterity issues, or hygiene issues, basically. You know, so if somebody has dexterity issues they can't clean, or if somebody has inadequately designed prosthetic, then you take it off. If you have a reason to, or if your gut's telling you to take it off, then take it off. And this, you have to just Google ACP position statement hygiene or something, you know, and they talk about single teeth, they talk about full arches. How I look at it, especially for these FP1s, I don't take off bridges and clean under that recall. And they're designed the same way I design my implants. And as long as they're keeping and the only difference between them is the implant epithelium or the implant attachment versus the tooth attachment. If they can clean around the implant attachment, I'm not seeing any signs of recession. I'm not taking it off.
Yep. Really good point. Okay, let's do two more. Okay. How about using external connection implants?
They work. Do you use them?
I don't.
Yeah, they work awesome.
I feel like the people that use them are like kind of old school prosthodontists.
100%.
It's only prosthodontists.
100, and it's usually like maxillofacial prosthodontists. They like.
Yeah.
But you know, the one thing you have to keep in mind as a doctor is that you design a fail-safe in your protocols. So I talk to my patients about this explicitly, and I'll tell them when we're doing these FP1 prosthetics, for example, that patient that had all that decay, I'm not really worried about bone loss. I'm worried.
She's not a bone loss type patient.
No, she's initially in the beginning stages. I'm maybe worried about early implant failure. Yeah. But after that, I tell her, if something goes on with you, you're going to be breaking this porcelain. Because she's breaking temps, she's breaking this. You know, what I worry about with you is breaking porcelain. Again, I'm going to design it the best that I can, and I really don't want that to happen. But if it does, I'm not going to lose sleep over it. I'm not going to cry about it. But what we did was I over-engineered your case. Typically, people do these cases with 4 implants. In your case, I placed 8. And if I lose 1 and I still have 7, I'm not losing sleep over it. If I lose 2, and if I lose 3, I'm still over the minimum, and we'll place it. But you know, you have to have these conversations with people. And so the reason I bring all that up is with an external hex implant, it's still an implant. It's going to integrate. It's integrated for years. It might have more bone loss than other implants, but the main difference is the fail-safe. Is it the screw or the implant that's going to break? And so you just have to kind of study what you want to be your fail-safe. It's the same thing with acrylic and zirconia. They both work. Zirconia will work, acrylic will work, hybrids, they both work. Are you more comfortable repairing denture teeth, or are you more comfortable repairing porcelain? You know, and so those are the decisions you have to make as a practitioner as to what you're going to recommend to your patients. And you have to be explicit about it too.
Yeah, I think the reason for me why I don't use external hex is because I don't have the biology aspect. Oh, we have 2 minutes left. Okay, we should finish this up. So I don't have the biology aspect because I can't place it subcrustal. Yeah. Because then I'll lose all that bone, right?
Exactly.
So if most implants in immediate cases for sure are placed subcrustal, and you'll lose that.
Yeah, and on a mandible too. I think that's completely different than on a maxilla, right?
Totally. Yeah. Okay, so closing remarks. I keep pushing this thing down. Thanks for taking the time. We almost did this for fun, 2 hours.
I know.
2 hours.
I love it, dude.
We need to do a course together. We need to spend more time.
Let's do it. I need an excuse to head out to California.
Yeah, it's really good weather out here. So come out here.
Come out here in the summer. Come hang out in the pool. Come hang out in the office, man.
I would love to come by. I would love to come by.
Love to have you.
I don't think I've actually spoken in Arkansas, have I?
Let's do it.
Maybe once. Yeah, let's make it happen.
Let's set it up.
But thanks everybody for coming. I will post this, and then I will also record it and put it on my YouTube so you guys can watch it for as long as you want. But if you're not following Dr. Sinada, make sure you go do that now, because his story is fire every day. It is good stuff.
Can't wait to get back in the clinic where we can do this full time, man.
I bet. Yeah, I know.
Yeah.
We're all excited to see our patients again and make people smile.
Awesome. Hey, thanks
for spending the time,
awesome.
taking time away from your kids, and let's do it again.
Let's do it. All right, guys.
All right, Naif. See you later.
Yeah.
Bye, everybody.